लगा है क्या तुमको?
मेरे को सेम ही
Hello. Hello.
So good evening, everyone. So should we start now? What is the format? 9 o'clock, should we start or should we wait for a minimum joining list? Good evening, Alimul ma'am.
Hello. Good evening, sir.
Yeah, I'm saying good evening, Alimul ma'am. She has joined actually. So then we will wait for at least 15. So in 5 minutes also, just passed already 5 minutes. Wait for 15 participants, then we should probably start as low as 15 participants join. So already 20 participants logged in. So I think that's a good number to start as we are on time. Good evening all. So today a topic which of interest for all the tertiary level neonatologists and probably all the neonatologists of the country will be presented by our DNB Neonatology trainee, first year trainee, Dr. Sheetal. This topic about improving outcomes in periviable neonates. The periviable, the word itself is still in gray zone. It applies to different country, different geographical region and different institution differently. So let's listen from Dr. Sheetal. So what we mean by periviable neonates and what are the best practices we can adopt probably, though we may not endorse with scientific evidence, but what we learn from this presentation through different practices of the best institute and best practices, how we can apply to our periviable babies. So with this, I just welcome Dr. Sheetal to start the session, and we can see the end of the presentation. Probably in the meantime also, I will invite all the participants to put the questions, and we will go for a discussion end of the session.
Yeah, thank you, sir. Good evening, everybody. I am Dr. Sheetal, and today I am presenting a seminar on improving outcomes in periviable. So, periviability is one of the greatest challenges of this modern high-tech era, because neonatology has progressed so much. So there was always an ethical dilemma going on in the earlier decade about the periviable neonates. But now, we have started actively managing these babies, the outcomes have started improving, and also the neurodevelopmental outcomes have also started improving. So we will be discussing about it in the following points: definition of periviable period, what is the present knowledge, what are the antenatal managements, delivery room management, golden hour management, system wise we'll see, and also we'll see the best quality practices which we can derive. So periviability, it is defined by different regions and different. Hello. Please, participants, can you mute yourself? So the periviable period has been defined by different organizations or different countries. So in India, it is defined as like full resuscitation is undertaken when the baby is more than 28 weeks. And we consider resuscitation if the baby is more than 25 weeks. So as per the ACOG American guidelines, full resuscitation is after 24 weeks, and consider resuscitation is at 22 to 23 weeks. So basically, when we know this is the time we can consider resuscitation, that is the periviable period we are going to target today. As per Japan, full resuscitation is there from 22 plus 1 weeks, Australia, New Zealand from 25 weeks, Sweden, and the periviable period we can see it spans from 22 weeks till 25 weeks. So we'll be discussing the same period. Here I would like to mention here that as per the UK, the periviable period which has been mentioned here is 22 to 23 weeks, but it has to 21 plus 1 week. So so what is the present status? There is a gap in knowledge regarding the optimal care of these extremely preterm infants. Whatever. Actually, your microphone, the participants, please. So whatever the clinical trials have previously for the care of the premature babies, few of the infants of the gestational age of 22 to 25 have been included in those trials. So there is lack of evidence for evidence-based practices and lack of uniform protocols. and most of the data it comes from the single centers or from the countries which provide advanced
Excuse
life
me,
support
presenter.
to premature
As a
babies.
host
So
can
if
mute
we
all.
see this is the table from INEO, that it is a collaboration of
Dr.
10
Sheetal?
countries where they have shown that
Dr. Sheetal?
survival, if we can see, the survival is fairly good at after 27 weeks. So around 20 to 29 weeks, we can see the survival is good in all these 10 countries. But when we go towards 26 weeks, 25 weeks, and 24 weeks, what we see is that there is a great variation. So not all countries do really well in this week from 25 weeks, 24 weeks, 23 and 22 weeks. And Sweden and Canada and Finland, which are leading, and we look up to these countries so that we can look up to them and see what are the practices they follow, and we can maybe derive some inputs from them. So the Iowa University, it is the university in USA. So it has given its statistics as survival in 22 weeks. Okay.
Second time pumping.
Survival in 22 weekers was 59%. This was the complete, like whole, all the live births who were not even admitted to the NICU were included in this. So if we look only at the NICU admissions, the survival was 64% at 22 weeks, so which is a remarkable survival. And also the 60% of the survivors had no mild neurodevelopment impairment at 22 months of adjusted age. So if we see between Iowa University and USA, so there is a large difference actually. Here the ELBW babies, if we see, this blue is the Iowa. The survival overall in the LBW babies is higher in the Iowa group than the one group. One is the rest of the US. So Vermont, Oxford, this they have seen in this. So overall, Iowa has fared better than USA. So we'll be not looking at USA in the further discussion. We'll be looking at Iowa. So best practices which we'll be discussing will be antenatal management, active management, active treatment. So then the antenatal steroids, antenatal magnesium sulfate, delivery room practices, delayed cord clamping, respiratory support, FiO2 which is given, and respiratory support, cardiovascular support, fluid nutrition, gastrointestinal care, and we'll be looking at the gut protective strategies. So first important thing is that in antenatal management is the active treatment. So if it depends a lot on if we are actively managing the babies, because there is a lot of variation in which 22 weeker, 23 weeker or 24 weekers. So they may be given an option of kind of going for active treatment. Depends on the international statistics, depends on the national statistics, and it also yeah. Hello.
కాదు డాడీ, ఇప్పుడు మొన్న పెదనాన్నలు పెట్టుకున్నారు కదా స్టేటస్. ఉన్నది కాదమ్మా, నేను ఇదని పెడుతున్నాను. అది చూడండి.
అది మనకి తెలియదు, అది మనకు రాకపోవచ్చు. అది ఆయనతో మాట్లాడుతుంటే నా దగ్గర ఉన్నాయి అని అంటే అయ్యింది రేంజ్ అనే దాన్ని బట్టి చెప్తున్నాడు ఆయన. అది మన రేంజ్ కాదు.
I'll pause the share for a second. I'll mute the participants, please. Just a moment, please.
Sheetal, you can
కుదరదు శాస్త్రం ప్రకారం. సేమ్ నక్షత్రం అది.
it's fine now. Sheetal, you can proceed.
presence ಇದೆ.
So active treatment does make a difference. If we offer active treatment at this periviable age, they definitely can, from the earliest, like even before the birth, then the outcomes are definitely different. So active treatment does make a difference. The thing is antenatal steroids. We all know that antenatal steroids are indicated in 24 to 34 weeks of gestational age, and they play a vital role in improving the survival of these babies. So what is the role of these babies in the pre-viable period? So from 24, 23, and 22 weeks. So it has been observed that the benefits of the steroids will increase as the gestational age goes down. So it is not that it is not helpful, it is more helpful. So corticosteroids are indicated in this age group. So here I can show you all the countries who are really faring well in the outcomes of these babies all have a very good antenatal steroid coverage, almost around 90% we can see. So that is a point which we can take notice of, is that antenatal steroids, if they are given in this periviable period, they will definitely improve the survival of these babies. So how much does it increase? Increases by almost 100%. So one study from Iowa, they have mentioned that the survival just doubled up. So that is the impact of antenatal steroids. Also, even if we cannot complete the full course, as we talk about other babies also, even a single dose can be helpful. Obviously, it won't be much, like it won't cause much impact, but it is definitely helpful if we give 1 to 23 hours before birth. So differences in the, I will be covering this into three regions, 3 countries. One is Sweden, one is Iowa, US, and the another one is the Japan. So what are the differences which we can find in these 3 regions? So antenatal steroid coverage it is uniformly high, and Iowa states that they have 91% antenatal steroid coverage. So magnesium sulfate prophylaxis for prevention of IVH, it has been mentioned in Iowa approach, and in Japan they are not using antenatal magnesium sulfate for prophylaxis of IVH. So this is something different. So delivery room management, it is usually uniform for all the countries, like these leader countries. They have a uniform approach towards delivery room management. So delayed cord clamping, then temperature maintenance, it is followed by all of them. So these are some good practices where we can see an embrace which is being heated and baby's mattress. And this is the heated humidified oxygen. It is one of the good practices which we can follow. So here the FiO2 is also can also be precisely given as we want. And we can see that the gases are humidified and heated. And there is definitely evidence that heated humidified air causes, it improves the thermoregulation, the temperature control of the premature babies around birth. So the delivery room management, if we see, so usually when we speak of a 26, 27, 28 weeker, we talk of CPAP. But how are these babies different from those 28 weekers or 27 weekers? These babies are a bit different because they are so extremely premature that they usually do not do on CPAP. So they usually require intubation, and there has been an evidence that 23 to 24 weeker babies have failed CPAP. So this is the FiO2 what we start with. Sweden starts with FiO2 21%. This Iowa starts with the higher FiO2, which is 50%, and Japan starts with around 30 to 60%, while NRP, which mentions, is 30% to start in premature babies. For a term baby, we advise to start from 21%, and we go up. But usually these preterm babies, they have oxygen. So NRP states start around 30%, but Iowa is a region starting at 50%. So why so much of difference if we see? The difference is that Iowa, this strategy, they feel that premature babies, if they are resuscitated with something like lower room air or maybe lower percentage of oxygen, these babies had a higher mortality. So they go with a higher percentage of oxygen to start with, and because they feel it also helps in reducing the pulmonary vascular pressures, and they immediately come down on the FiO2. And this the minute oxygen saturation table for the of the NRP, it is followed by them, and so they come down on FiO2 immediately as soon as the baby starts maintaining the saturation. So it is not that FiO2 is maintained for a longer time. Even the same thing with Japan. So the main thing in delivery room management here is to avoid hyperoxia, and also we avoid hypoxia, because these babies are also vulnerable to hypoxia. So that is the key point where which we can remember over here. Then delivery room management is these babies have been intubated in all these three sectors. So they were not tried CPAP or any other non-invasive ventilation. So in Sweden, the baby was intubated, babies are intubated with 2 to 2.5 endotracheal tube sizes. They are placed on ventilator and ECG leads are applied. In Iowa region, bag and mask ventilation is given for first 30 seconds, and then the baby is intubated with 2 to 2.5. So usually a 22 weeker is intubated with 2, and if the baby is 23 weeks, then they go for a 2.5 mm ETT. While in Japan, what they do is they prefer a 2.5 mm ETT, and if it is not passing, then they go for a 2 mm. 2 mm. The reason being they put the babies on HFOV later. So the baby, initially they place the baby on a conventional ventilation with a VG of 4 to 6 ml. And details are that in Iowa, they have specifically mentioned that the intubation is done in a very calm way by a senior neonatologist. So that is the thing they have specifically mentioned. And the ET depth at the lip is 5.5 to 6 centimeter in the three different countries. So here we have to take a notice that it is usually 5.5 to 6 centimeters for this very small babies. So surfactant, what are the practices followed by Sweden? They give delivery room surfactant Curosurf 160 mg per kg. It is a slightly different dose. The Iowa, they give instillation of surfactant within first hour of life in the NICU after radiographic confirmation of the ET position. And also the Japan does give it in 6 hours of life. So it is also after chest X-ray confirmation of the ET position. So these two countries, they differ in, they don't give delivery room surfactant. So what is the what we see regularly is that immediately in the delivery room, the surfactant is given to premature babies who is already intubated. So we definitely give it in the delivery room only. But this approach is different to here. They shift the baby to an ICU and they wait till the X-ray is done. And after the confirming the ET position, then only they go ahead and give the surfactant. So why they have mentioned here, there is one from the Iowa. This is the X-ray. So when very small babies, so ET can go to the right main bronchus, and it can cause only the intubation of the right lung. And if we give surfactant to if we give surfactant in the delivery room, then it may cause inadvertently more damage than causing. So the other lung stays without surfactant, and there can be risk of pneumothorax in the right side. So the babies are transferred to the NICU. Then bagging is done while transferring a baby from NICU to from delivery room to NICU in Iowa. So what is the initial mode of ventilation? So this is a major difference. In Sweden, the baby is put on a conventional mode of ventilation with VG of 5 ml per kg. And the first intention high frequency jet ventilation is used in Iowa. So they will put a baby immediately within 10 minutes, they'll put the baby on high frequency jet ventilation. And in Japan, they will put a baby on conventional ventilation, and if the baby requires looking at the cardiac function, then they will shift the baby to HFOV with VG of 1 to 2 ml per kg. So this is the main difference in these three countries. But what is the basis they have mentioned? They aim at avoiding polytrauma like over distension, and they also aim at avoiding, because they feel this 22, 23, 24 weeker babies, they are very much prone for pneumothoraxis and this interstitial leaks, air leaks. So that's why they go with very gentle ventilation and avoiding overdistension. So the Iowa, they mentioned that they have found very good experience with high frequency jet ventilations, and they have found that the babies have come out really well. Even if the babies had PIs or pneumothoraxes, they have done really well. So in the Sweden, they start with P max of 24, PEEP of 5 in the delivery room, and when the baby shifted to NSU, they come down on the PEEP to 4. The rate is 40 to 60. FiO2 is started at 21%, TI is kept at 33. And in the Japan, they will start, if the baby needs to be shifted from conventional to HFOV, then the map which is set is 2 to 5 centimeters above the map which was used in conventional ventilation. Or if the baby is initially being taken on like HFOV, then the default map will be 12. So side breaths, there is an important difference here, that Sweden doesn't add any side breaths. Iowa, they add side breaths 4 per minute later in the course of the disease if the baby is having desaturations or atelectasis, microatelectasis. And in Japan, side breaths are regularly added at 3 per minute. So if we see, NRP also does not recommend any side breaths even during resuscitation, but this is different from what is like advocated by NRP or what is practiced. So target saturations, if we see, they are 85 to 90 in Sweden, 84 to 93 in Iowa, and Japan it is 90 to 95. So Iowa has mentioned in their paper that they were using a saturation of 87 to 95. But what they found, when they decreased the saturation limits to 84 to 93, the mortality did not increase and the ROP levels came down. So they are targeting the saturation limits of 84 to 93. And Japan people, they have written in their these outcomes that ROP has been the most, like it has been very high in their population. And what are the initial PCO2 goals? So in the Iowa, they have specifically mentioned they will avoid hypocarbia very strictly, and also avoiding not going for hypocarbia. So 45 to 60. Sweden goes with PCO2 targets. So prophylactic indomethacin, it is given in Japan and it is not given in any other country. And sedation, when the baby is on ventilation or so what is the sedation? Sweden, they will not do any sedation and they will do minimum handling. Even Iowa people, they will do minimum sedation and they will not give any sedation and do minimum handling. And Japan, they have used fentanyl drip earlier, but then they found that there was 4 back-to-back cases of spontaneous intestinal perforations. So they have shifted to phenobarb, are avoiding opioids to prevent meconium ileus, which is associated with diabetes and to prevent the spontaneous intestinal perforations. So this is the mortality Japan has shown. The lowest mortality of and the ROP level is very high in Japan. So if we compare with other countries. So differences in cardiac assessment. So how do they approach this small babies? So Sweden, what they will do, they don't give any routine inotropic treatment. Iowa also, they will not use any routine inotropes. But Japan, they will routinely start a baby on dopamine and dobutamine whenever the baby baby is admitted on HFOV. So the dopamine and dobutamine is given at initial policy. And if you look at echocardiography, Sweden cannot do any echocardiography in the first week. And even if PDA is there, they don't treat PDA in the first week. The reason they state is there is no difference in outcome or mortality even if you do not treat the PDA in the first week. So this is their approach. The another approach which is taken by Iowa is that they will do targeted neonatal echo screening for hemodynamically significant PDA and ventricular dysfunction, starting in 12 hours, and they'll repeat it over like 12 to 36 hours. They will be doing it, and this 2D echo is done for assessing for ventricular dysfunction and impaired venous rhythm for babies on HFOV in Japan. So systemic steroids are avoided in Sweden. Stress dose of steroids is given for transitional hypotension in Iowa babies, they can give for 3-4 days, or they may extend it for 1 or 2 days more also. And in Japan also, systemic steroid support is given in view of adrenal insufficiency in these premature babies. If we look that Sweden has not given any specific statement about the BPC hypotension hereditary. Iowa has said, hello, huh? Yeah, actually,
I think it's Dr. Naresh.
hello. So basically, Iowa statement is that the mean BP does not reflect the cardiac output. So the mean BP is not considered for. Also, we do not have. Also, we do not have. Hello. So basically, systolic hypotension, if it is there, then the presumed pathophysiology is low cardiac output. If diastolic hypotension is there, the presumed pathophysiology is the systemic vasodilation. And mean BP is not the thing which is targeted in IO strategy. Then the Japan, they routinely use dopamine and dobutamine, and also nitroglycerin is used if there is condition with narrow pulse pressure and high afterload. So inotropes are completely avoided in Sweden. So they won't be monitoring a baby and doing adjustments in the status of the baby like frequently. They won't be doing it at all. And in Iowa statement, they have said that we strictly avoid use of dopamine because dopamine is a non-specific vasoconstrictor. It will cause abnormal cerebral autoregulation. It will increase the pulmonary vascular resistance. So it has very kind of unpredictable vasoconstrictor profile. So dopamine is strictly not used in Sweden. And if there is hypotension, low diastolic BP with pulmonary arterial hypertension, then vasopressin is a drug which is preferred. And if there is low diastolic BP with PH but without much hypoxemia, then noradrenaline is preferred by this Iowa. And in Japan, if there is hypotension, dopamine and dobutamine are increased gradually in 1:2 proportion as needed. So primary mode of extubation in Sweden is nasal CPAP and transition to nasal non-invasive ventilation, that is NAVA. So even in Iowa, NAVA is the preferred mode to extubation when the baby becomes greater than 850 grams. And if the baby has apnea, if the baby has apneas and the respiratory status is fine, then the baby can the baby goes to conventional mechanical ventilation. But if respiratory cause is the main thing, then the baby is taken on back on high frequency jet ventilation. So here we see that the baby is shifted from extubated from high frequency jet ventilation directly to NAVA. So there is no conventional mechanical ventilation in between. And also in Japan, from HFOV, the baby is extubated to CPAP, nasal CPAP. So if we look at the timings of extubation, in Sweden, the timing of extubation is 29 weeks. And in Iowa, it is median is 31 weeks. And in Japan, it is still more, it is 36 weeks. So they have given statements like Iowa has in their paper, they have written that why do we extubate so late? Because otherwise we say that we want to extubate the babies quite as soon as possible. We want to reduce the rates of BPD and all. So then why are they extubating so like delayed? So the thing they have mentioned is if we try to push off the babies and if they are not ready, and if we have extubation failures, then that is going to be more kind of harmful to the babies. So they have mentioned here in a population of 24 to 27 weekers, if there is a failed extubation within the first week, then the mortality increases significantly from 6% to 28%. So Iowa has a statement that this mortality is completely avoidable. So they will they will extubate the baby when the baby is ready. And Japan has a still more delayed kind of extubation protocol. So when we go to the cardiac status, cardiac management, we see that Iowa has, they will do the targeted 2D echo from 12 hours to 36 hours, and they will look at the shunt volume. So if there is a small PDA, then obviously they'll wait. If it is a PDA with moderate to high volume with a hemodynamically significant, then they will treat with paracetamol 15 mg per kg per dose 6 hourly for 12 doses. So after 3 days, they will repeat it 2D echo. And if it is still persistent, then they will complete 7 days course, that is 28 total doses. And then again, reassessment will be done. And if the baby is failing this paracetamol treatment, then the baby will be taken on indomethacin for 3 days. And then if it still remains significant, so basically they are not aiming for closure of the PDA, because these small babies, they are not looking at closing the PDA, they are looking for decreasing the shunt volumes. So if the shunt volumes are still high, then there is at the end of the second week, they will definitely approach this surgical closure. So here, if I show you for the PDA, they have a specific Iowa PDA protocol. So there are few parameters they see. It is not only the shunt size they are looking, and maybe the LA-OA ratio. They are also looking at multiple other parameters, even the aorta, peripheral blood flow, it is forward or reverse. So looking at all this composite score, if it is more than 6, then only it is treated. So this is Iowa PDA protocol. And if we look at Japan, then they will also do 2D echo from day 1, and it is done multiple times a day for looking at not only at the PDA, but they look at the contraction status, and they actually do a lot of other indices also they will see. So the treatment is highly dependent on the cardiac status. And if we see if the baby is having a hemodynamically significant PDA, then the baby is treated with indomethacin and brufen, and then the baby goes for surgical treatment. Paracetamol is not used over here. And if the baby has pulmonary hypertension, inhaled nitric oxide is used. And sedation, morphine, fentanyl, they have mentioned, but they avoid using it. And also they will use diuretics, furosemide, milrinone, nitroglycerin, depending on the status of the baby. So if you look at the fluid and nutrition, what are the differences? In the Sweden, the baby is cared in incubator, and there is a recent study published by them where they are mentioning that they are starting early and prolonged skin-to-skin contact, and even in a very premature baby. So it starts with a room temperature of 28 degrees Celsius, and for minimum 2 hours it is done. So small baby like 22 to 24 weeker, they will start doing the skin-to-skin contact by day 7. And if the baby is more than 24 weeks, it will be done as early as 3 days. So they have started this early skin to skin contact. And the IO approach, it is different. They put the baby under radiant warmer with a blanket called as a saran blanket if the baby is less than 1 kg. And they do not put the baby in an incubator with humidity. The reason behind that they state is they want acceleration of the skin maturity as fast as possible. So they will give high total volumes, like they will start at 150 to 200 ml per kg per day from day one, and they may go up to 350 ml per kg per day. So that is a very high target volume, total volume they are giving per day. And they will be giving it at 3 different fluids. So one fluid will be dextrose, which we give normally. One fluid will be dextrose free through the UAC, and one fluid will be 2.5% D, which is called as a carrier fluid. So depending on the sodium, depending on the urine output, and depending on the weight of the baby, they will be doing the fine calibrations of the how much volume needs to be given to the baby. And the Japan, they will care the baby in incubator. They will start at 90% humidity, and they will decrease as per the skin maturity. And they will start at a target total volume of 60 to 80 ml per kg per day, and they will gradually increase it. So this is the Indian scenario where wherever the centers are caring for the like ELBW babies, not ELBW, extreme premature babies. So these babies are usually cared in incubators in India. So if you look at the fluid and nutrition, so the Iowa people, they will go in the first 2 days, they want to avoid hyperglycemia very strictly, and they also want to avoid hyperlipidemia. So the initial GRs, they are really very less, 4 to 6 mg per kg per day, and they will gradually build on it after the 3rd day. And the Japan, they start with 8 to 10 mg per kg per day from day 1. And protein and amino acids and lipids, there is slightly variations. But here, what Iowa wants is mainly give amino acids as early and as fast as possible. And that is the main thing they are targeting. Because they are giving so much of large volumes, they also aim to give more of amino acids. And also lipids, they avoid lipids in first 12 hours of life because they have found some kind of negative this outcomes when the lipids were started in just after birth. So even the Japan, they have very cautious approach towards increment in lipids after the in this periviable period. So what are the gut protective strategies? How are they different in these 3 countries? So if we see no endomycin prophylaxis, it will be a gut protective strategy. So people Iowa, they will strictly avoid endomycin. They won't give prophylaxis. And if endomycin needs to be given for any other like PDA, then they will avoid giving it along with hydrocot. So because if endomycin is given alone, 5% risk of spontaneous intestinal perforation is there. But if it is combined with hydrocortisone, then it will increase that percentage 5 to, it will jump to 19%. So it is, they avoid it strictly, giving together. And Japan, they will give endomycin prophylaxis for IVH. And early initiation of feed is common for all. So are there any other like probiotics? Probiotics are being given by all of them. And none of them is using a single strain. All of them are using this multiple strain probiotics. And there is one difference that Iowa, when they are starting feeds for these very small babies, they will not give the feed as a bolus feed. They will give as a pump feed. And in Japan, it is given as a bolus feed. So when the Iowa, whenever they start feed, first thing they want to ensure is that the baby is passing meconium, the meconium stools have cleared, and they want that the gut should start mobilizing and the meconium should be out. So if they will start glycerin enema, and it is given 3 to 5 times, like they will, it is not a glycerin suppository, it is the enema. And even Japan, they will give glycerin enema 3 to 6 times per day, and the glycerin comes as 50% preparation. So it can be given original or half of the dilution, like half of the dilution. If it is given original, the dose is 1 to 2 ml per kg. And if it is given as 25%, the dose is 2 to 5 ml per kg. And in Iowa, if the baby is not passing enough stool, and if they are suspecting the meconium is staying back, then they will do a contrast enema by the end of the first week. So they think of it as a therapeutic thing to get the meconium out. So that is the thing they really aim, so that the baby doesn't land up in meconium ileus and meconium this obstruction and perforation, NEC and perforation. So these are the good practices which we can kind of see or follow. So actually this is the NS which is being taken and the glycerin, if it is diluted together and it is given directly per rectally without any NG tube to the baby using a 1 cc syringe. So other thing is a probiotic. This is we are not endorsing any brand. So this is also a multi-strain probiotic which is commonly used, and it has 4 strains of probiotic. So how it is prepared? It is the whole sachet is emptied into 8 ml of added with 8 ml of distilled water, and 1/4 of it is given in this pre-viable babies. If the baby is the dose here is 1/4 of the sachet OD. And looking at the skin care, so if when we want to protect the skin, here we can see that the ECG leads are not applied to avoid skin abrasions, and the monitor we can see the IBP is giving the heart rate and the BP. So we are avoiding we are protecting the skin. So again, protecting the skin is using deodorant, and this is definitely. Also, one more thing is there for this extremely preterm babies, we do not use sterilium or this back to prep. We will use a normal saline for like cleansing of the skin, even before procedures, even before the aseptic procedures. So IVH prevention strategies, how are they different? Japan is not using antenatal Maxelf. They will be using postnatal this indomethacin, and mode of delivery. It has been shown that there is an association of vaginal delivery and association with IVH, especially in this premature babies. So LSS is preferred in Japan, especially when the baby is 24 weeks. That is a preferred mode. But in Iowa, there is no. It is not the LSS is not kind of encouraged, because already it is a tough decision to take, because both for the mother and the baby, looking at the baby's kind of prognosis thing. So it is not advocated. But in Japan, it is done at 24 weeks. LSCS is done, and also the extubation practices they make a difference, because Japan they specifically state that we want to avoid the IVH and neurodevelopmental impairment. Therefore, we want to avoid the baby getting extubation failures and micro atelectasis, this atelectasis trauma and all. So we want even the hypoxias and apneas. So we are protecting the baby neurologically, and therefore we are extubating the baby when the baby is more mature kind of. So that is the thing where they are stating. And so these are the extubation practices which can definitely impact the IVH. So Japan, they have a special, they are looking at the intracerebral venous Dopplers. So here we can see if there are more fluctuations, in the So usually what we do is MCA Dopplers we will do. So Japan, it is doing something differently. They are using the internal cerebral vein Doppler, and here if the if the these fluctuations are more, then it is associated with more of IVH. So here we can see pattern 3 and 4, they are associated with increased risk of IVH. And one more thing they are seeing in the 2D echo is that end systolic wall stress of the LV. So they have seen that if the end systolic wall stress of the LV is more, and if it is accompanied by poor cardiac function, then it is said to be associated. It is said to be a risk factor for IVH. So they are not only looking at the resistive index or the MCA Dopplers, or looking at the IVH grades after the IVH happens. They are proactively looking for what are the factors, like they can detect it earlier and they can start maybe dobutamine or milrinone drip, and they can take control of it better before. Like this is the IVH prevention strategy which is being practiced in Japan. And Japan also kind of boasts of the minimum, like least of the IVH incidence in their premature babies. So starting out life as a preemie is not hopeless, but it's important that these babies require active treatment quickly. Even the smallest babies, they have a chance to live, and if they survive, a good life is likely. So it is really not that kind of hopeless as it was thought earlier. So the key take-home points from my presentation, I would like to say are active management of these premature babies. It does make a difference. And then developing a dedicated integrated structure and culture for these extremely premature babies. It is very important. And antenatal corticosteroids, they are encouraged to promote intact survival of these babies. And delivery room management is that we should avoid hyperoxia as well as hypoxia, especially in these babies. And in ventilation, the thing we can use conventional, we can use HFOV, and we do not endorse any of that this is better or that is better. But important fundamental principle here is gentle ventilation and avoidance of hyperventilation, hyper kind of over distension of the lungs, avoidance of volutrauma as well as atelected trauma around the extubation, and extubate the baby only when they are ready. And especially these 22, 23, 24 weekers, they should not be extubated, especially maybe in the first 3 days. Definitely not, because the IVH incidence is maximum in this first 3 days. And when they are really ready, so then only they should be extubated. If they are ready, they will show the signs. So the early extubation protocol, which is being kind of encouraged for maybe 27 or 28 weekers, that really does not apply to this 22, 23, and 24 weekers. So extubation should be a fine balance. It is not that we are going to prolong it very much, but it should be a fine balance. So not to push them, but whenever they are ready, then they should be extubated. So thank you all. Any questions we will take? Sir?
Thank you, Dr. Sheetal, for
Yes,
your
sir.
presentation touching all the points of whatever the neonatal care of extreme preterm babies. Periviable, as you highlighted rightly, it is different in different country. When we are not sure in India, below 25 weeks, the resuscitation, how it goes. And below 28 weeks, when the statement says to full resuscitation still a concern below 28 weeks. So India, what we are considering below 28 weeks, maybe that will be very different in the already countries like Japan, Sweden, where they are taking care of 25 weeks to 25 weeks, 22 to 25 weeks very happily. So periviable period is different, so practices be different. But what we learn from those extreme small babies, as per your discussion, probably we can apply to our smaller babies, which can be helpful for us. That's the important point here. But the questions, we will try to sort a few of the questions. Let's answer a few of the questions. I have answered here. One important question someone asked, what is the periviable outcome of your unit? So I will try to clarify here. It is not individual units outcome is not important. Here we are discussing among the different best outcome units, what best practice they are doing to get the outcome better. So here, but to say the percentage wise, I already showed here. So 24 weeks around more than 50%, 52% almost outcome, and 25 weeks 69%, and 26 78% outcome in our unit, which this extreme small babies I'm saying. And number wise, I say around this combination number, around 370 babies of 24, 25, 26 babies we have discharged. So that's the outcome per our experience. So during this process of learning, when from outcome, when we were not taking care before few years, 24 weeks, and last 6-7 years we are taking 24 weeks, around 52 babies of 24 weeks we discharged home. So slowly we are learning from those best practices. And few of the practice we adopted, though we don't endorse saying that it's happening in Japan, we should do blindly. It's happening in Sweden, we should follow. But by this discussion, we learned few of the very good things. Like antenatal factor, what to achieve and how to achieve the antenatal, like steroid good practice, achieve towards 90%. And even the smaller babies, if there is intention to treat for a 23 weeker or 24 weeks weeker or 25 weeker, there should be our target should be the best possible antenatal steroid coverage up to 90%. Then our achievement probably the result will be better. Like neuroprotective magnesium sulfate, though all the units across they are not doing uniform, as the guidelines says below 30 weeker. So if you are taking care of small babies, we should try to achieve magnesium sulfate. Best possible in utero transport, taking care the delivery in a tertiary level hospital when the care can be started beginning can influence the outcomes. They all the centers they agree. And remaining individual things before going to individual things, I will say if some of the practice questions you will try to answer, then Dr. Sheetal, you can answer. Glycerin suppository, you have seen the experience here. We are doing for last 8 years almost, but you have seen practically how we do normally. You want to answer that, Dr. Sheetal, what we do for glycerin suppository?
Yes, sir. So the photograph is from the unit only, sir. So basically, we routinely start glycerin suppository to the, it is not suppository, it is an enema, sir. And it is equal dilution of the NS and the glycerin. So that glycerin is 50%. And so we make it 25%. So the dose for this small babies, the dose will be like 1 to 2 ml per kg. So we give 0.5 plus 0.5 is what we give routinely. 0.5 plus 0.5, we make it 1 ml and then we give it BD. And if the baby is not passing meconium adequately, and if we feel is there any abdominal distension or any feed intolerance, we can, or if we have like apprehensions about the this tummy, then we increase the glycerin enemas to TID, and some like TID I have seen, sir. And if the babies are like bigger, then it is given more also. But in this premature babies, I have seen 8 hourly we are giving, sir.
So smaller the baby, sometimes though the dose is smaller, we use little more frequently. The smaller the baby, 3 to 4 times in 24 hours, we use glycerin suppository. Little bigger babies, twice sometimes helps. So we go with 2 to 3 times, then we require 3 to 4 times. But small dose, 0.5 ml plus 0.5 ml, 1 ml we use normally. The syringe they wish we sold. That's one precaution we taken care this last so many years. We are not putting an NG tube into the rectum. So never we got a tear and perforation. Never which hub we use, and slowly we pass the picture from Japan practice, and same thing we are doing. We are pushing anything inside. And some units they push a few millimeter, 0.5 millimeter to 1 cm, the NG tube they introduce and they push the content inside. But we are putting through the hub only, which is few millimeters only. So that's probably helping us in decreasing feeding intolerance and passing the meconium cleaning. Probably which we assume it helps, but do we have a trial, do we have evidence? No, but it's some good practice which helping us in the day-to-day practice. We learn from there, we are doing also, and other units showed this. But before, one question I want to answer about that, and then I will request Sheetal. Dr. Sheetal, you unmute Dr. Umang. Say maybe a question and doubt they may ask actually. Some people, if they say unmute, please unmute. You are the host, so you can unmute there. So before question was incidence of VAP. Incidence of VAP, more the longer the period of intubation, definitely it is higher. So the longer duration of extubation, like 29 weeks, 31 weeks in Sweden and Iowa, when they talk about 22 weeks to 25 weeks. 26 weeks onwards, they promote delivery room CPAP and mode of non-invasive way from ventilation. When the question is delivery room only, we target CPAP and non-invasive mode of ventilation. No question of extubation there. So very, very, very small babies worried about IVH, worried about mortality, worried about SIP. They keep little prolonged period till the baby is suitable and fit to extubate. But the risk is there, definitely VAP. So what our experience, I will say, we prepared a colostrum kit. So that is 5 to 6 years before we started that, and the practice is very regular. And VLFW baby, any less than 1.5 kilo baby, we clean the mouth with a few drops of fresh colostrum, 3 to 4 days in a day. With that, we saw our VAP incidence definitely decreased. So that's practice we adopted, the colostrum kit. few units like Sweden nursing protocol has written that it is from Sweden, but we are doing since long actually. We don't know where from we got which protocol, but we are using for less than 1.5 kilo, which is helping in this babies. So definitely longer the duration of ventilation, the longer the tube foreign body inside, the biofilm production and the BAF incidence higher. We should be careful about that. But each day around time, we should assess, can I extubate, but which may not be applicable to these very, very fragile and small babies of 450 gram, 400 gram, or 500 gram, or 600 gram. So, which is coming in India, many units now discharging 500, 600 gram. They may come in this group, and then we should be careful. So, probably that I will say. And before that, did you, Dr. Umang, unmuted?
Yeah, sure.
Please,
First of all, yes, thank you, sir. First of all, many congratulations to Dr. Sheetal. I mean, this was an excellent presentation. I mean, I'm yet to hear a better presentation. I mean, in the past, in my DM. I'm a 30-year DM resident from AIIMS, New Delhi. I have a few questions, if you don't mind. Like, what is the rate of advancement of the feed? So, do you advance the feed within 1 week or 2 weeks if the baby is tolerating, or do you keep them on MEN of around 40 ml per kg for some time and then advance the feed? Because we have seen that many a times our babies land up in feed intolerance and NEC after advancing from 50 to 80 and 80 to 100 and 110. And we quote literature that rapid advancement is associated with shorter duration of stay and lesser infection. But what we have seen is quite opposite. That as soon as we shift from 50 to 80 in a 600 gram baby, he will lead to feed intolerance. And secondly, how long do you continue the TPN? So will you continue if you reach 120 and only 30 ml of IV fluids are you giving? Then also are you continuing TPN, or you stop TPN before, or you stop only after the full feed is reached and the baby has tolerated for 3 to 4 days? So this was one of the questions, and I have 2 more questions if the time allows. But please, if you can answer this.
Dr. Umang, first of all, thank you for concern. Thank you for the question and the concern, because the way you sound actually really practically that we face. Many times it's a full feeding, but may not be all the babies we reach full feeding early. Early aggressive feeding is good idea, but in the small babies, your concern is actually genuine. So if I will speak here, I will divide the extreme low birth weight into 2 categories. In our unit, if you talk about 28 weeks and above, our feeding is very, very aggressive. We probably, the way you ask the question, 30 to 40 ml, we start in the first day, and second, third day, we quickly go on. But if you talk about 26 to 28 weeker, little slow. But for the babies of 23, 24, 25, 26, these 4 weeks, we specifically last few years, I can say 5 to 6 years, because this all aggression starts 5, 6 years back when the 24 weekers more. So we follow I eat protocol. I eat protocol, that's the simple table formed by Japan protocol also. The same I eat protocol, US University protocol, so same followed by Japan. So they start normal, we'll see. There's a risk categorization there where we go for first 3 days very slow. The risk category is less than 29 weeks, IUGR, Doppler abnormality with abdominal distension clinically, we are going very slow. Very slow means first 3 days, no advancement, 0.5 ml, second hourly feed, we continue. After that, the advancement is 0.5 ml to 1 ml per day. So by 11th day to 17th day, we reach the full feeding in those 24, 25, 26 weeker. But if you will talk bigger babies, 9 to 11 days, normally we reach full feeding up to 28 days. 28 and more, I don't think more than 5 to 6 days to reach the full feeding.
Absolutely, sir, I agree.
So smaller the baby, the slower the advancement. Presence of risk factor, we should be careful in our approach, because all babies are not equal. Though the gestation is same, IUGR component, Doppler abnormality, clinically after that. So these are all things we should see. And second question, I did not get the second question, please, Dr. Umang. This is the first advancement. Second question.
So till how long do you continue? So by the
TPN.
time, TPN.
Yeah.
So how long do you continue the TPN?
So TPN, if you will ask us, there are practice points for the lipid. I will talk. Lipid, we go to 3 grams. We don't go to 4 grams normally.
Okay.
And the amino acids, we go to 3.5, maximum sometimes 4. We start day 1. So we advance slowly. proteins also from 2 gram to 3 gram to 3.5 gram advance over 3 days. But 100 cc reached, we stopped lifting, which we give 18 hours in a day out of 24 hours. 120 to 140 cc we reached, we stop aminovan. But not stop, we start weaning from 100 cc. So 3 gram to come down to 2 gram, because by 60 cc to 100 cc we start fortification. By 60 cc, if human fortification milk fortifiers, we use 60 cc, and the HMF what we use, by 100 cc we use HMF. So cumulatively we calculate it should go over enteral and oral to 3.5 to 4 gram protein, that way we do. So usually we try to remove early, but saying so, this small babies 500, 600, 750 below, they actually require 14 to 15 days slow advancement, accordingly the TPM requirement.
Sir, and what fortifier do you use?
Fortifier in two forms we previously in India, as you must be aware, the human milk fortifier was available commercially before the controversy. So first few days, 2 to 3 weeks, we use that. And after that, we switch over when the baby is stable, full feeding, we switch over to human milk fortifier, which is the cow's milk source. Fortifiers we use normally. Now also we are using same thing. But
Electrobiotics only.
For particularly 24, 25 weeks, 26 weeks, first use it 2 to 3 weeks. Whenever we started this multi-component cow's milk source fortifiers, we are a little worried about gaseous distension, abdominal distension. We were worried a little bit.
And sir, one more thing, like, what do you do to if you get into a cycle of PI and high pressures, and then further more PI, and like the baby goes into desaturation? So how you manage PI? I think HFJB is not available in India, I think so at present. So how do you manage the PI? Is there a way to get out of the PI cycle of hypoxia, PHN, and then further hypoxia?
We are, if you're treating small babies, BPDs is a collateral damage. It comes with a package.
Exactly.
And the severe BPDs with the PI changes happens, everybody should agree. But our target should be to prevention. If we can successfully prevent the cases by Indian specific infection control, because many times the steroids covered well 2 doses, and the babies first initially we start caffeine, we give VG volume guarantee ventilation, gentle ventilation, wean faster. In 26 weeks onwards, babies we get less definitely. But infection sometimes second and third with infection changes the scenario. So infection control, fluid reduction, fluid management strictly with the PDA babies, and probably aggressive nutrition for the growth help can help those changes. But if it happens, which happens in NICU, tertiary level NICU, small babies, we are dealing dreaded desaturated babies are residents' nightmares. That's we know always. So for those babies, a jet ventilation is not there, but we try to manage with a little bit of higher PWP with recruitment of the lungs, avoiding equally the hyperinflation, atelectasis equally. So with a volume of 5 to 6 ml per kg to compensate for the airway, we try to manage, but with a good PWP 6 or 7 sometimes. If that fails, as per our guideline, we use HFO, not a primary mode. We use HFO as a rescue mode. So those conditions and many PIs we handled with the frequency, high frequency jet ventilation not available, but oscillatory ventilation we managed well. When we struggled with hyperexemia, hypoxemia, more than 60 to 70% FiO2, once we started recruiting with the HFO, we managed well those babies. But we do, that's the part and parcel of the care when the extreme small babies we take care.
Okay, thank you, sir. Thanks a lot. It was really, again, I cannot appreciate this presentation enough, and look forward for more of this presentation. Thank you.
Thank you, Dr. Umang for the interaction. And few other questions still there to go ahead. Dr. Sheetal, do you want to answer whether fungal prophylaxis needed to be given?
Yeah, sir. So, like regarding the country-wise approach, sir. So I'll start from there, and then maybe I'll talk about the unit protocol maybe. So Iowa has mentioned that they give fungal prophylaxis as nystatin or fluconazole. So, but they give it only for 2 weeks. So they are not using the humidity at all. So they want to accelerate the skin maturity. So they estimated around 2 weeks, they will be using the fluconazole prophylaxis. And so though it is advised for 6 weeks, Iowa use it for 2 weeks. And Japan and Sweden, sir, I couldn't find the specific mentions. But in our unit, we do use fungal prophylaxis, especially when the long lines are there, and this smaller babies, we use fungal prophylaxis for 6 weeks.
No, please enumerate the dose, frequency, and how many days we use. So it will be a information for everyone. No?
Yes, sir. So the dose for prophylaxis is 3 to 6 mg per kg, and it will depend on the gestational age. So it comes alternate day. So we start at 3, sir. 3 mg per kg alternate day. And when the long lines are out, we do stop the fungal prophylaxis. Until the long lines are there, we continue, sir. And the maximum is 6 weeks, sir.
Yeah, if the book wise, you will see the recommendation wise, if the fungal infection rates are higher, that fungal prophylaxis is useful. If it is less, probably it is harmful by introducing a high resistant fungal colonizer will be there. So the units which are already getting more fungal infection, probably the right idea. The book wise, if you see less than 1 kilo baby, to start early in the day one, if the central lines like UVC or PIC line later it is there, and to continue up to 42 days. And for more than 1 kilo baby up to 1.5 kilo, it is 30 days, 20 to 30 days. That's the standard protocol. It may not be consensus, but protocols are there, existing protocols in European protocol. But if you'll ask us, we are using, but we use till the central line is there. The day central line is there out, the PIC line is out, the UVC is out, we remove them. Because UVC, we hardly keep 4 to 5 days. We don't, even the smallest baby, we don't go for more than 4 to 5 days. We put PIC lines, but 1 or 2 PIC lines might require in the throughout the care parenteral nutrition. But once the PIC line is out, we stop fluconazole. We don't target 42 days or 30 days as per the book protocol recommendation. That's question, interesting question. Antibiotic prophylaxis 25 weeks baby is baby requiring multiple interventions. We are very aggressive in antibiotic stewardship. Put the checklist for the antibiotic check. If we start due to any risk factor, as early as possible, 48 hours, the culture negative. If no inflammatory markers, baby stable, we'll try to take it out. And the question again quickly, because time is constraints, I am coming to any experience of ansystolic wall stress. No, we don't have direct any experience, though we have our point of care ultrasound, 2D echo, we do ultrasound, we do. But as per Dr. Sheetal described, we have done few of the extreme small babies, 24, 25, 26 babies, internal cerebral vein, Doppler with a pattern, recognized pattern. That is a patterns are described there up to 4th category. So last 3rd and 4th category, when there is an undulation of the diastolic phase, 24 to 48 hours before the real IVH, we sometimes got the clue. So the cerebral monitoring for predicting a IVH, which Japanese has done, we have not done very commonly, but with the smaller population we have done. So we saw some of the times we get a clues. So babies probably with a higher diastolic pressure during ionotropy use and very struggling babies or inserting babies, sometimes those features we get. And after 2 days or 1 day, we see that the baby is going for IVH grade 2 or grade 3. So that we use, but we have no experience on cardiac and systolic wall stress. That's maybe some of the cardiac units may be doing. Japan described, but we have no experience in that.
Sir, I am Dr. Aditro. I have passed my DM from Kalavati, and it's an excellent presentation, sir. So I have just 2 or 3 questions, if time permits.
Please.
First, sir, whenever you're doing the cerebral venous Doppler marking, and do you do anything when you predict increased risk of IVH, like category 2, category 3, when you see those type of patterns?
Yeah.
Do you do anything specific?
Yeah, absolutely. You are right question. A perfect question to the, probably I'll say you are asking the right question. If I know I don't act, then why it is so? So after probably using this one same time, we have written a protocol. The blood pressure, gestational age wise, every baby is 24 week, 25 week, 26 weeks or 27 weeks up to 28. We test week wise blood pressure, 3rd centile and 25th centile. We place the systolic, diastolic mean blood pressure. So now after seeing that, we don't respect much the mean blood pressure. If my systolic blood pressure okay, perfusion okay, I'm not changing. And if this turbulence, we saw a little bit probably lesser blood pressure we target, and we add sometimes dobutamine if the pulse pressure is narrow. It helped us. And we see 24 hours after those Doppler multi-normalized. It normalized due to our not targeting higher diastolic dobutamine use. I'm not sure, because this is a new thing where last 2 years we are doing in few opportunities only, because small babies are less. But we saw a trend, a pattern, which little bit response but stabilized with dobutamine. So
Sir, yes,
that's
sir.
exactly dobutamine help, but we are not targeting higher BP. That help, we don't know, but it helps us.
Yes, sir. I have also similar experience with that dobutamine. And second thing is, do you target NIRS in those babies?
No.
Cerebral
NIRS we have NIRS we have NIRS machine in-house. So we are doing for other purpose. For now we are planning for other studies also, but we use few cases of refractory hypoxemia and PPHN. But extreme small babies, little bit we could not place that properly. Our handling and care providers, nursing staff and doctors, we are not comfortable with the specifically NIRS. Though we used on the hypoxemic PPHN babies, but not extreme small babies brain circulation.
And sir, if time permits, I will ask another practical question, because the SPAGAN guidelines told that to supplement phosphate from second day or third day.
Yeah.
So whenever you're giving phosphate, how you give phosphate with calcium? Do you add another peripheral line for that, or you add it in the end of that three-way cannula in the central line?
Achha, this is a practical question, India specific question, because the customized TPN which is prepared already contains phosphate, but India we prepare ourselves amino differently, lipids we take
Yes, sir.
differently, we use calcium gluconate, we use phosphate differently. So we
Yeah.
monitor phosphate, and the first 1 week rarely we get low phosphates. We got it 1.4,
Okay.
2.3, 1.8 the phosphate level, scary. We got few babies, but it's not quite common. 3.5, 4.5 levels in first 1 week. First 1 week after only we get a low phosphate. So first 1 week, the potassium which is supplemented, potassium chloride in the TPN. But once during monitoring, we get a phosphate. First week, twice phosphate we monitor. Second week onwards, weekly we monitor. If it is low, we enteric feeding, if 60 ml plus, 60 cc plus or 80 cc plus enteric feeding achieved, little easier to use a calcium phosphate preparation orally, 1 ml 6 hourly or 0.5 ml 6 hourly to add on. But if still we are not very good enteral feeding by that time, phosphate low, we use pot first 0.3 ml per kg in a separate line, but connected to the same UVC different port or the PIC line and another extension ports. We saw that if we mix into the same syringe pump, there is a chelation.
Yeah. Yes, sir.
But
exactly.
if we are using to the most proximal part of the lines, we did not get any blockage of PIC line, which we worried initially. We did not get any blockage.
And second practical question is, sir, in these extreme preterms, we usually get a non-anaerobic metabolic acidosis due to extreme loss of bicarbonate. In Western countries, they use acetate in their solution, but we don't have acetate. So how you tackle this NAGMA, non-anaerobic metabolic acidosis?
Yeah. Right question. Right question. Extreme small babies, extreme questions, extreme rare situations we will see. So in few of the countries, when I check the literature, they use the umbilical artery ports, very low dose of, they use bicarb, which is very, very small dose. And they use in the heparinized saline, they don't use, they use the plain saline and use small dose of bicarb. But you will ask me, are we doing in arterial? No, I reviewed in 22 weeks to 25 weeks when the volume is very, very, very important. Why to lose that arterial USC volume? So they are plain saline and bicarb they use. But what we do for the last few years, we use 100 cc, 80 cc, or 120 cc, 140 cc. If we see the trend, when the other buffers like hemoglobin is good, not looking septic, hemodynamically stable, the PDA is not issue, but losing probably bicarb, we estimate the urinary bicarb also, sodium also. And losing stays, we use 20 ml per kg of isolate P. Sometimes 20 ml to 30 ml per kg of isolate P in that volume sorted out our this loss, because it's what's converted into bicarb by the liver, this product from the isolate P. So if that takes care of the problem, it's fine. When it happens -10, -12 borderline, it comes down to -8 or -7. We don't target further low, because that's fine for extreme small babies. But if in case we are not achieving -18, -20, sometimes constantly 3-4 days, we see there is a baby stable. So sometimes 2 milliequivalent or 1 milliequivalent over 24 hours after third day of life. First 3 to 4 days, we don't do those because we know that's not loss. In the end of first week, we see this loss phenomenon more and more. So those time, we just supplement 1 to 2 milligrams over 24 hours supplementation. No bolus, no push, no correction. Only over 24 hours, we try to supplement it.
Sir, ISO-P or RLs are you use?
And
For
ISO-P,
that-
ISO-P, no RL, ISO-P.
Okay. And
20
sir,
cc per kg, maybe 120 to 140 cc when we reach now. From that,
Okay.
MMN will be there, that's lipids will be there, feeding will be there. But just 20 cc per kg, we give isolate P, which helps.
and sir, last question, that is, whenever you are using probiotic in these babies, Japan's literature shows that tells that they use probiotic in either mixing with the feed or either mixing with the normal saline and then only using the supernatant part. Do you use in that way or you just use it directly? Probiotic.
No, they are worried about the diluents, the osmotic load of the diluents, which is the corn product.
Okay.
The Japan probiotic, the excipients which contains corn,
Yes, sir. Yes.
which will have a high osmotic
Yeah.
load. So 1/4 dilution they do one way, or they completely dilute it to 4 ml and the supernatant they use. You are right about the practice. But what we face, this is, I'm talking about this 11 years back when our NEC rate was around stage 2, stage 3 NEC rate was 6.2, 6.1. We started 3 important things that particular time, 11 years always say. We irradiate our liquid depleted irradiated blood, we use PRBC, which we say LRBC, and we little threshold, we don't come to 6, we use 7, 7.2, 7.1 we use, except the first 3 days of life. So little early, you can say. We use probiotic that lasts 11 years and glycerin suppository 6 to 7 years we are using. With that, incidence came down definitely. Now 3%, below 3% in those extreme small babies, less than 1 kilo babies I'm talking. I'm not talking bigger babies. It was 6.1, 6.2 in less than 1 kilo. It is 3 around. Now with this practice of blood collection, probiotic use, and this glycerin suppository, and the I eat protocol, the feeding protocol I eat, we are using things long. So this when we use this one, this probiotic we use, we are worried because no dose was written how much to use. We are now also worried because we don't know the dose, but though people are using 3 billion per day, we are using 1 billion to 1.5 billion per day, per kg. But when small dose, 1/4 of this powder sachets, we take the weight of that and mix it, we did not find any difficulty there. So when content may be getting difficulty, but the question you are asking now in newer terminology is coming parabiotic. Parabiotic is biochemical property of the probiotics mixing into the water, which diffuses can work probably well. So I'm not sure about those practice. We use 1/4 to 1/2 of the sachet, depending on the body weight, mixed into the distilled water, and during the milk, we give that one, during the milk feeding.
Okay, sir. And just a last question, I don't know, time permits. That is in high frequency ventilation, what I have faced in personal experience, sometimes if there is a secretion and you don't have a volume guaranteed high frequency ventilation, then the PCO to fluctuation is very much high. So what is your opinion on taking care of this situation, sir?
Tom babies, more than 2 kilo babies, we don't have an issue now.
No,
Sir.
I'm asking about periviable.
Inline suction are there, more than 2 kilo, we use routinely.
I am just asking about this periviable babies, sir.
Yeah. Just when this is smaller babies, if HFO there, HFO usually rescue and for continuous use. We are unlikely very friable or very labile saturations, like unlikely the PPHN. So whenever there is a secretion, we HFO time always we try not to discontinue, not to breach the circuit, because we immediately face a de-recruitment. But whenever it happens, with taking into neopuff, unlikely the handbag, taking into neopuff with the 6 or 7 PWP, keeping them in the circuit and suction, we do, and they tolerate well because the analgesic components also there, so they tolerate well. But the PPHN babies, whenever we did a PPHN baby, very labile babies, we did a HFO suction, there were very fluctuation. Suddenly the saturation will fall quickly. But more than 2 kilo babies, we are getting less because the inline suctions are there. Still, with the inline suction also, unless there is a visible secretion, we try to avoid suction routinely in HFO. And that's the right practice everywhere, probably everyone must be doing. Nothing new. But the extreme small babies, long term, when we use constantly for 3, 4 days, 5 days, or 6 days, during this recruitment phase and continue. And those phases, occasional suction can be discontinued with neopop, can be done.
And sir, do you use steroid allowing surfactant in these babies?
That's not routine practice. We used and we sent for publication. It is a review phase now. We use Budecort combination with Curosur. And so trial RCT already completed and we have sent for publication. But is it a protocol? No, it is not a protocol. It is for the under the purview of RCT. So we used. I don't think that's the evidence. Is the till now evidence is guiding us to go ahead with the Budecort combination with the surfactant. We used during the trial phase with the ethical clearance, and when we completed that, it's not a standard protocol for us.
And excellent with discussion, sir. Excellent discussion.
Thank you all. Probably we are exceeding time 10:30, but I liked the discussion here, but the discussion for learning. So I am happy that we talked, a lot of discussion here happened, and I will request Dr. Sheetal to share the PPT in the group, and so that anything if somebody missed due to the interruption in the voice or the network, thus learning should continue. And best wishes for this IAN platform. So all the people should regularly participate and learning should continue. Wish you all a happy learning. So probably we are going to close here the session.
Yeah, thank you, sir.
Thank you, Dr. Sheetal. Thank you for a nice presentation and stimulating a lot of questions which we discussed. I hope we clarified the doubts well. Thank you.
Yeah, thank you to you, sir. Thank you so much.
पापा ने खा लिया मम्मी? अच्छा हाँ